So, hi there, welcome to the Physios in Sheffield. I'm Johnny Cassidy, I'm one of the team here. I'm joined by my colleague Paul Hattam, and this is knee osteoarthritis, injection therapy for knee osteoarthritis part 2. I had lots of questions at the end of our last video. I just thought it would be really good to clarify some of the stuff.
Sure.
So, at the end of our last video, Paul, we talked about Jeff.
Yeah.
Must note that isn't Jeff's real name. But Jeff had a really grotty knee, so I treated Jeff as well. And an HA injection, got about 18 months, 2 years relief. Yes, he still needed surgery. But just in your experience, injection HA so far, is there a consistent response to it, usually?
Well, that's a good question. I mean, because as soon as you say that, there's a few people that kind of spring to mind that have done less well. So it's not a universal 100% treatment for every single person, but they are few and far between. And I would say that the vast majority of people who have HA do really well. In fact, there are people now that just keep coming, every year or so will reappear, before a ski trip or before a marathon or, some kind of event, because they know that they feel different afterwards, and actually that they've got better, they can run longer, or they've got better function of the knee as a result of the injection.
Yeah, nice. And I suppose, both of us are now independent prescribers. I think the injection therapy thing's so good, I've joined you on one of your courses. But there is always a bit of an argument to combine the properties of the steroid, the anti-inflammatory properties of the steroid, with the benefits of hyaluronic acid. Would that be your take on that as well?
Yeah, I think that sometimes it's difficult to make a judgment in terms of who's going to benefit most from steroid and who's going to benefit from HA. The steroid is a very powerful anti-inflammatory, and so it has quite a dramatic impact on the inflammatory process within an arthritic knee. And so that can often give very immediate, but often quite short-term benefit. The HA tends to give a more of a longer lasting effect. So a lot of the studies looking at the efficacy of HA show that around 13 weeks is kind of the optimum length of sort of benefit. In my experience, it's often much longer than that. But combining the injections is an attractive proposition, because it allows you to have the immediate hit of the steroid, but also the longevity of the HA. So there's a good argument for using both, I think.
Yeah. I suppose hopefully there's possibly some people out there going, oh, this HA, I didn't know about it, maybe that's for me, and maybe somebody who's got a really sore or debilitating knee, and maybe they don't want to have surgery yet. It's important to know that in our practice here at this place, it isn't just come in and have an injection.
Yeah,
we would refuse to do that.
Yeah, that is really important, because it's not only backed up by our own clinical observation over the years, but there's quite a lot of research now that shows that combining injection therapy with effective rehabilitation over quite a period of time gives much better outcomes. Also, people who've got arthritic knees have got other issues in terms of not really knowing how much they can load a knee. Some people have got weight issues which need to be addressed. Most people kind of stumble into osteoarthritis of the knee without really knowing how to manage their condition. And so there's a lot to be done around an injection. And I think injecting in isolation is always a no-no.
Yeah. And I suppose, just for anybody watching, it's probably really important that somebody has a really good assessment of your knee before you go anywhere near injection therapy.
Yeah, absolutely.
We need to make the right decisions whether you need this combined injection which requires a prescription, or whether you need one or the other injection.
Yeah. I think you're right. The clinical examination is everything, because everybody's management is going to be different. Osteoarthritis is not just kind of an overall diagnosis that everybody gets the same treatment. Some people won't need an injection at all, and may never need an injection. Other people we may be suggesting they get an opinion from a surgeon straight away because their knee is more advanced. So I think the assessment is absolutely critical, and I think from that comes a discussion with the patient, because people's expectations vary as well, and people's objectives and goals vary. So I think making sure that the treatment is tailored to what people want to achieve is really, really important. Yeah. So once you've done that, then the treatment plan unfolds, and I think that's something that's agreed and discussed, and people will want to engage with, because at that stage they understand that that's the route to recovery. And that can be rehab in our studio. It can be hands-on manual therapy to help restore function of joints, and then an exercise program people can take away with them, and to get the outcome they need.
I think it's really interesting when you look at patient goals. I've got a chap that I'm seeing at the moment, and the only thing that he wants to do is play football with his grandson. And I think people come along and they think that it's just a bridge too far, or that's a request that they shouldn't be making. And to play football with grandson in the back garden, that's a perfectly adequate request.
Absolutely.
Just really last question before we finish. Do people need to go and see their doctor or their GP before they consider an injection?
Well, the short answer is no. As you said, we're both prescribers, and so if somebody does need a steroid injection, then we can organise that, write a prescription, and get that into the practice. No, people can come straight here and have the injection. The only thing I would say is that we like to work with GPs in the area, so it's, if somebody does come along and need that kind of treatment, in the same way as any other treatment, we would want to communicate to the patient's GP. So we kind of want to work as a team and see that as an integral part of kind of achieving that, really.
Well, that's it. Knee osteoarthritis injection therapy part 2. And just a few of the questions that spilled over from our first session. And be sure to check that out if you haven't done already. There is lots of information on our website about injection therapy, about hyaluronic acid, about what that process and that sort of, as we really strive for gold standard care for our patients, what that journey looks like. And also lots of information about how we are covered by insurers and Westfield policy and that sort of thing. But yeah, I hope you enjoyed knee osteoarthritis round 2.